These are my disclosures. Hi, my name is Cecilia Damask. I'm an otolaryngologist in private practice in Orlando, Florida. I'm excited to talk with you today as part of the pre-work for the advanced management of chronic rhinosinusitis and the Unified Airway course. This lecture is part of the pre-recorded and on-demand lectures available starting January 22nd through February 5th. The live in-person portion starts January 29th in Dallas, Texas at the Warwick Melrose Hotel. There will be live lectures and panels, as well as a hands-on nasal endoscopy session. There will be ample time for you to interact with our world-renowned faculty in a smaller, more intimate setting. Come get all of your questions about CRS with NP and asthma answered. More information about the course can be found at www.allergycrs.org. We hope to see you live in person January 29th. If you can't attend in person, the live portion is also available via live stream from virtually anywhere. Chronic rhinosinusitis with nasal polyposis, or crswnp, is a predominantly type 2 inflammation-mediated disease of the nasal mucosa and paranasal sinuses, affecting up to 4% of the population, with an underrecognized and underappreciated clinical, social, and economic burden. Patients with CRS with NP experience a high symptom burden, including things like nasal congestion, rhinorrhea, and anosmia. And this has a negative impact on their physical and mental health related quality of life. This affects things like sleep quality and emotional consequences. Existing medical and surgical interventions, including things like local and systemic steroids and also endoscopic sinus surgery, may be associated with recurrence of their nasal polyp disease and the associated symptoms, and also may be associated with increased risk of short and long-term adverse effects, especially with repeated or long-term use of systemic steroids. Because type 2 inflammation is implicated in the pathogenesis of several coexisting diseases, patients with CRS with NP often have comorbid asthma and or aspirin exacerbated respiratory disease or NSAID exacerbated respiratory disease. These patients, as well as those with high systemic corticosteroid use and or cyanonasal surgical history, have more severe disease and higher associated symptom burden. Indirect healthcare costs of CRS with NP include societal costs related to absence from work, called absenteeism, decreased work productivity while at work, called presenteeism, and also other forms of lost productivity, things like leisure time lost. These are measured in terms of time, like work days lost, or they're measured in terms of dollar equivalents based on prevailing wages. Absenteeism relates to societal costs related to absence from work. In a multi-center study on quality of life and absenteeism in patients with CRS referred for endoscopic sinus surgery, European investigators found that 57% of CRS patients reported absenteeism from work due to their CRS. Absenteeism due to chronic sinus conditions is considerable. A nationally based household study was conducted to determine the disease burden of sinusitis relative to other medical conditions. Patients with sinusitis were significantly more likely to visit the emergency room, spend greater than $500 a year on healthcare, and also to see a medical specialist than those who didn't have sinusitis. Patients with sinusitis missed an average of 5.67 workdays per 12 months versus 3.74 workdays lost for those without sinus disease. The number of workdays lost with sinusitis was similar to that of acute asthma, which had an average of 5.79 workdays lost. In a multi-institutional study from Rhinology Clinics, Rudnick et al. Found mean annual rates of absenteeism to be 24.6 days. A total of 21.2 household days were lost per year related to daily sinus care requirements. This translates into 61.2 million potential workdays missed per year among adults in the United States. This translates also to an estimated work productivity loss of $3.79 billion per year. Presenteeism relates to decreased work productivity while at work. In a prospective multi-institutional observational cohort study from Rhinology Clinics, Redmick et al. Found a mean annual rates of presenteeism to be 38.8 days. This study used the human capital approach to define productivity costs. The overall annual productivity cost was $10,077 per patient with refractory CRS. Productivity costs increased with worsening disease-specific quality of life. This substantial cost to society provides a strong incentive to optimize current treatment protocols and continue evaluating novel clinical interventions to reduce this cost. Smith et al. Investigated CRS-related facial pain and productivity losses and found that facial pain had a strong correlation with presenteeism, which is a main driver of productivity losses and indirect costs associated with CRS, with an overall loss productivity at about $20,300 per patient per year. Previous studies have shown declines in productivity due to CRS are correlated with disease-specific quality of life measures. However, it's unclear which symptom domains contribute primarily to productivity loss. Chaudhry et al. Sought to assess the association between CRS-specific quality of life subdomain impairment and productivity loss. In a prospective, multi-institutional observational cohort study, they found that the mean annual productivity cost was about $11,000 per patient, whereas with comorbid immunodeficiency, it was about $23,000 per patient. With comorbid tobacco use, it was $23,000 per patient. And for steroid dependency, it was about $18,000 per patient. In a study evaluating correlations between post-treatment changes in symptom subdomain and productivity loss in patients undergoing active continued medical management for CRS, their work-related productivity losses were still approximately $4,500 per 90 days. In a comprehensive review, DeConde and Soler found the indirect costs related to decreased productivity from CRS were estimated at $12.8 billion per year in the US. We're now going to examine other forms of lost productivity, mainly leisure time lost. The indirect costs of CRS are not only work-related. Stankiewicz identified a 40% rate of impairment of activity with CRS. The results from his study indicated that sinus-related health problems impose a substantial burden on physical, and mental activity levels. Bhattacharya determined social and cognitive limitations in 9% and 6%, respectively. We're now going to move on to the individual burden of CRS. We're going to look at health state utility scores because they're particularly helpful for comparing the burden of different diseases because these instruments measure disease impacts using a single common metric. Health state values or utilities are a measure of preference based health related quality of life, and they're often used by health economists. They are unique in that they represent an individual's valuation or preference for being in a particular state of health. This differs from generic quality of life instruments, which quantify a health state based on symptoms and functioning but do not ascribe a value. Health state utilities are defined on a scale from 0 to 1, with 0 representing death and 1 representing perfect health. The use of a single common metric allows for meaningful comparison across disease states and interventions. The goal of this study by Solar et al. Was to determine the health state utility values in a prospective observational cohort of patients with CRS before and after endoscopic sinus surgery. And then to assess the meaning of these values by comparing them with other chronic disease processes. Adults aged 18 and older with CRS were prospectively enrolled and observed over a period of 5 years. Enrolled patients had to have symptomatic CRS despite medical treatment, and for which they had elected to pursue surgical treatment. Health state utility values were determined both before and after surgical treatment. A total of 232 patients with CRS were enrolled. The mean utility value for all patients with CRS was 0.65. The baseline health state utility value of CRS patients was found to be well below the weighted average normal for the US population of 0.81. The mean utility value for CRS patients is similar to what is seen in many other chronic diseases, but worse than things like CHF, COPD, and Parkinson's disease. By definition, patients with CRS will suffer with some combination of cardinal cyanonasal symptoms, including nasal congestion, nasal drainage, facial pressure or pain, and loss of sense of smell. However, the impact of CRS often extends beyond the sinonasal region and can have profound effects on functional well being and general health related quality of life. Numerous studies have explored the burden of CRS using general health related quality of life. There are several patient based outcome measures used in CRS, and I'm going to focus on SNOT-22 as I believe that this instrument is something that can be easily incorporated into use in clinical practice with our CRS patients. I personally use SNOT-22 in my practice on a daily basis. SNOT-22 is a disease-specific health-related quality of life instrument for use in CRS. The 22-item sinonasal outcome test, or SNOT-22, is a modification of a pre-existing instrument, the SNOT-20. The SNOT-22 is a validated self-administered questionnaire that is used to assess CRS patients. The SNOT-22 consists of 22 items rated from 0 meaning no problem at all to 5 meaning the worst possible symptom. Possible SNOT-22 total scores range from 0 to 110, with higher total scores indicating worse symptoms. The SNOT-22 was derived from the rhinosinusitis outcome measure 31 that was developed by Piccarello. The SNOT-22 provides one total score that measures health status and health-related quality of life in CRS patients. There are 6 domains in the SNOT-22 score. These include nasal, non-nasal, ear, facial, sleep, fatigue, and emotional consequences. When responses of CRS patients are examined in detail, the most common extra sinus disease manifestations include fatigue and bodily pain, sleep dysfunction, cognitive function, and depression. Importantly, these extra sinus manifestations are often the drivers of overall health state utility scores and patient decision making. Severe fatigue is commonly reported by patients with CRS. A systematic review by Chester et al. With meta-analysis, including data on over 3,000 patients from 28 studies, examined fatigue in patients with CRS. The baseline median prevalence of fatigue was 54%, ranging from 11 to 73% across the studies. Poor sleep quality is a frequent complaint of patients with CRS. A large population-based study in Europe found that sleep problems were 50 to 90% more common among subjects with CRS as compared with the general population. A case-control study by Alt et al. Explored objective sleep changes, finding that patients with CRS have increased number of awakenings during a night's sleep. They also have increased rapid eye movement sleep latency and spent a greater portion of the night snoring at more than 40 decibels. Potential mechanisms of sleep dysfunction in CRS include alterations in nasal airflow and direct effects of different cytokines. But these hypotheses remain speculative, and further research is required to understand the association between CRS and sleep. Another prominent factor that impacts overall quality of life and well-being in patients with CRS is the increased prevalence of depression. A systematic review found prevalence rates for depression in CRS ranging from 11% to 40%. This wide range likely reflects differences in patient populations and the diagnostic accuracy for depression. For example, differences included patient report, physician diagnosis, validated questionnaire. Regardless, the frequency of depression in patients with CRS is above population norms of between 5 and 10%. The comorbid presence of depression is associated with worse sinus-specific and general quality of life compared to CRS patients who are not depressed. Not surprisingly, those CRS patients with depression have higher healthcare utilization, including increased antibiotic usage and physician visits, as well as more missed workdays than CRS patients without this comorbidity. Universally, patients with comorbid depression and CRS have worse sinus-specific quality of life at both baseline and postoperative time points compared to those without depression or even after controlling other factors. Patients with CRS with NP experience high symptom burden, which has a negative impact on their physical and mental health related quality of life. It's important for us to recognize how much CRS within NP impacts the quality of life of our patients. I want to thank you, and I want to tell you that I look forward to seeing you in Dallas in person on July 29th. Hope to see you there.